All right, well, why don't we get started then? So welcome everyone to the July Prostate Cancer Support Group out of running attached to the SAN Cancer Support Centre. We've got Dr. James Symons as our special guest speaker tonight, talking about the current concepts in prostate cancer management. So without further ado, I'll hand it over to you, Dr. Symons.
Thank you very much for having me. Again, sorry, things are slightly delayed from where they were last year. COVID's been, its own individual journey for a lot of us, I guess. Thank you for the kind words. I'm a urologist at the SAN. I work at the SAN in St Vincent's, but the bulk of my time is spent up at Sydney Adventist Hospital, which has an excellent cancer support service, from diagnosis through to aftercare, as I'm sure a lot of you will be aware. So I do some things at St Vincent's. Oh, sorry, I just had a meeting about your recording pop up right in the middle of my screen. This is sorry, and I've got no control over it. Something strange is sorry about this, everyone. Hopefully that's back to where we were. And I've consulted Eastwood as well. My details are there and you'll have them all. Essentially, what we're here to discuss tonight is about prostate cancer and general concepts with it. Now, a lot of people here will have prostate cancer. The thing to be aware of is that prostate cancer for a lot of people is going to be a chronic disease. And as a consequence of it being a chronic disease, it's something that's going to be needing to be treated not just at the cancer diagnostic stage, but also across the journey moving forwards. A lot of people with prostate cancer will still have their prostate. As such, they're still a man and they still will have BPH symptoms. I think that's something that historically hadn't been looked at or dealt with all that well. And a lot of patients with lower urinary tract symptoms would be allowed to continue to not so much suffer, but live with diseases and bladder dysfunction that could otherwise be best avoided. It's also coming to the fore that patients with urinary tract symptoms are better off to be treated earlier in the disease process rather than later. So whilst it's incidental to prostate cancer to an extent, if you can treat a man's benign prostatic changes early on in the piece before it has too much problems within the bladder, as they become an older man and develop prostate cancer, then they'll get better function from that as well. So it helps to avoid some of the urinary symptoms that you'd otherwise like to try and avoid. One of the things why is prostate cancer important for me? What might you want to tell friends and family? Well, the prostate essentially is an organ that derives itself from within inside the prostatic urethra. So before a person hits puberty, there's really not much of a prostate to speak of at all. So the prostate as a gland forms within inside the really proximal, so the high up part, which is called the prostatic urethra. And it develops, from puberty in response to the testosterone surges that happen. It takes on all different shapes and sizes. And that's one of the reasons why there's quite a bit of variability between the different treatment options that you might suggest to somebody for their benign enlargement, and also why different people will have different responses to surgery. Not everybody is going to be the same. The different approaches that we'll use surgically, there's quite a bit of nuance depending upon how the apex looks, and that will have an impact upon positive margins. It'll have an impact upon urethral length preservation. It'll have an impact upon what degree of bladder dysfunction that they'll have. The prostate anatomy, it's a very complex space down there with lots of prominent blood vessels around the place. It can be associated with significant bleeding, particularly in the old days of open surgery, although less as we got better with our techniques. And there's also some critical nerve structures, which a lot of you will be aware of, running alongside of the prostate, which contribute towards the sexual function and dysfunction that men may have. Now, as I said, why might we actually want to talk about urinary symptoms? We're not just here for prostate cancer, we're here for men's health in general. LUTS, so L-U-T-S, is a terminology which is the over-encompassing term for lower urinary tract symptoms. It used to be referred to as prostatism, and so a lot of GPs may still write in letters about patients suffering from prostatism. People will talk about their prostrate, contributing towards their urinary symptoms. And look, a lot of the urinary bother people may have may be secondary to the prostate, but not all of it. A lot of it's actually going to be secondary to the bladder as well. And the way that the bladder wall, the muscles within it, will adjust themselves to compensate for what the prostate causes with regards to the degree of obstruction. These are some pictures from a cystoscopy, which I did several years ago. As we push up through the prostate, you can see those two sides causing opposition. Then we enter up and into the urinary bladder. So this person's got quite large bladder stones sitting in there. Those bladder stones will have developed after years of urinary obstruction. They form from the urine, which is crystallized. So basically the urine crystals start to form if the bladder's not emptying properly. The crystals coalesce and we have big stones sitting in there like this. And they can certainly develop in patients who have prostate cancer as well. Now, some of the symptoms of a man with male LUTs, sorry, not cuts, I made a typo on there. Obviously, there's going to be the deterioration symptoms, so the flow starts to become a little bit more problematic. It's going to be a little bit more hesitancy to get the urinary stream started. But there's also lots of social issues that can happen if people are having incontinence. And so a lot of people will find that they need to restrict their activity. They may be a little bit more reticent to go out and about as they were in the community for fear of accidents. And as things progress, you can end up with quite significant issues with bladder's not emptying properly. You can end up with chronic renal impairment with pressures going back up into the kidneys. People end up with catheter dependence, a whole host of issues, what's otherwise going to be a relatively treatable scenario. In the old days, people didn't really get a lot of treatment. As we progress, we're getting better and better. It's really hard to go doing a study anymore, actually just observing patients. You can't just look at a man and say, look, you've got symptoms. Let's just observe a group of 100 of you and let's see what doesn't happen. But that was actually done in the 1970s in England. And they watched a group of men and they tried to see how their symptoms progress as they progress over the next couple of years. You could do a lot of stuff back then, which isn't really ethically sound at the moment. And what they saw is if you watch people who have prostatism, so to speak, is that very few of them actually reported that symptoms got better. Most of them reported that the symptoms got worse. So as a chronic disease, the prostate starts to, enlarged prostate starts to put pressure up and into the bladder, and then that can cause all sorts of, social dysfunction. A lot of people will start to normalize their dysfunction. And so that means, people will start to get up once a night. They think, oh, it's okay, it's only once a night. And then they're getting up twice a night. Oh, it's only twice a night. The real thing is how often is too often. So patients will come to me and often they'll say, look, I'm happy with their once a night. The reality at a technical level is that anything more than 0 is considered to be abnormal. So there's lots of classifications for lots of things, but nocturia, which is getting up at night to pass urine, is always considered to be abnormal. People will normalize it, but if you look back to where you might have been in your 20s and 30s, unless you had a little bit of grog on board, it's very, very rare that people actually need to wake up to urinate. The brain makes an antidiuretic hormone, the kidneys go into a shutdown state, the bladder doesn't have overactivity going on, and the bladder is basically a nice storage reservoir to then allow the urine to fill up, and you pass urine in the morning. As the people age, you start to get some dysfunction coming in. Now, it's quite common for people to get arthritis as they get over, but arthritis is still an abnormal aging process. The same sort of thing happens within the bladder. You get some wear and tear, so to speak, happening, and nocturia starts to build into that. Now, so it's never normal. You should be able to sleep through the night. Now, a lot of these things will start to actually manifest themselves from the age of 40. And look, you might say, look, this is the prostate talk. Why are we talking about this? We'll come to that in a sec. It's prostate cancer talk. It's because of what happens to the bladder if we don't go treating this. And so essentially, if you don't go treating the prostatic enlargement earlier on in the piece, these are men in their 40s and 50s, as they progress, they start to get quite significant changes in the bladder muscle. And so this is actually a really challenging thing to go treating, both within my benign patients and also amongst my patients who have prostate cancer. If I go surgically removing that enlarged prostate, we're still left with this really thick-walled bladder behind it. It's a bladder, the muscle of which is now having difficulties with relaxation. It may be okay with its contraction, so it's a really strong muscle. It's like someone's been at the gym lifting a lot of weights. It can lift really strong things. It can squeeze really strongly. It can push urine through that prostate, but it's not so great at relaxing. And because it's not so great at relaxing, the storage capacity of it decreases. Then I go taking the prostate out. I've essentially opened up the dam, and we're totally reliant upon the pelvic floor muscles and the sphincter to give a man his continence. The bladder behind it isn't as supple as it used to be, years previously. As a consequence, as that bladder starts to fill, the pressure within the bladder starts to rise, and men start to feel more urgent. They start to feel like they need to urinate. And they tend to be feeling like they need to urinate at relatively low capacities because that bladder doesn't like stretching. Because people have a fear of leakage, because they will be aware after they have an operation that they might leak a little bit, then they end up starting to urinate more often. And so they try and minimize the risks of leakage by starting to urinate at lower and lower volumes, and people start chasing their own tail. And so one of the things that we do with bladder retraining is to try and teach people to actively defer urination, to try and teach them it's okay to have a few leaks here and there, but what you want to do is actively try and hold off urination in the early stages of the desire to urinate, in order to stretch up that bladder wall, to try and get some suppleness back, try and get some compliance back to it. As an unfortunate rule, however, just because a person's got a large prostate, it doesn't necessarily mean that they will have a significant degree of bother. So, the body's quite good at compensating for things, and not all men with a large prostate will actually end up needing to have, treatment done. And so, however, nevertheless, conversely, if you've got a big prostate and you've got symptoms, almost invariably you'll improve somebody's urination if you de-obstruct it. This is what a bladder which is really worn will look like, and so it's got significant overgrowth of that bladder muscle within it. The bladder wall should be smooth. It shouldn't have all these rows of muscles and creases around the place. Actually, it looks like Mr. Muscles on the right-hand side. With regards to the urinary frequency, different people will have different degrees of comfort for themselves. Really, how often is too often really depends upon you, the patient. It doesn't really depend upon me. My role isn't to make a happy man happy. As somebody who's comfortable with their degree of urinary frequency and control, they're happy. But plenty of people will be bothered by how often they're going. For some people, every 2 hours is too often. For others, every 3 hours is too often. There are people who will put up with things until it's happening every 10, 15 minutes, which is really quite significant. To some extent, it's going to be affected by the fluid intake, but particularly the fluid type. There's a very strong link between tea, coffee, and alcohol. So the caffeine and the alcohol is going to be a diuretic. It will also irritate the bladder lining. It's got quite astringent properties. So you get this fluid load that comes into it. It irritates the bladder lining, and both caffeine and alcohol decrease the body's production of the antidiuretic hormone. As a consequence, people will be making excess urine. Excess fluid will come through and can quite significantly irritate people's degree of bother. The bladder, this is from the slides I gave at a conference, when we're doing conferences regularly. The bladder's response to bladder outlet obstruction is an adaptive one. So initially, there are these compensatory changes that happen to the detrusor muscle. Basically, the detrusor is the name of the bladder muscle that causes overactivity, which means it's relatively twitchy at relatively small volumes, and the compliance, which is the elasticity of it, is decreased. And these will then give these characteristic features that people will describe. So it's going to be the increases in urinary frequency, the getting up at nighttime, nocturia, and also some incontinence. As it's allowed to progress, you then get these decreases in the actual muscle itself. So the pump starts to fail. And unfortunately, there's no medication to fix the decreasing pump mechanism. So you can try and decrease the overactivity at the top. There's nothing that you can really do from a medication perspective to fix a failing pump. And that's when the stream starts to really slow off. It's a bit of a stop-start phenomena, or if people are keeping stagnant urine left inside. I've alluded to some of these dietary changes, so basically decreasing caffeine consumption to fix some of the initial bother. But also, there's a great role for decreasing somebody's excess abdominal weight. More exercise is often going to be the key for a lot of things, and it comes into prostate cancer risk, as we'll see later on as well. Also, I'd like patients, if they've got some sleep apnea, to try and get it diagnosed, and also use their CPAP machines if they've been prescribed with it previously. There's a significant link between the obstructing airway and patients waking up at night and needing to urinate. Now, we'll probably jump over this in the interest of time, but essentially early on in the piece, we might start with some medications, and then there's some surgical procedures that we can jump into to make basically the hole through the prostate a little bit more open. these are things that will free up the urinary flow. It takes the pressure off the bladder, and then decreases the issues that a patient has post void. They're not going to be keeping all that stagnant urine left inside. So for this patient, we've got an obstructive prostate beforehand, the two sides, like that person earlier with the stones, and then after I've operated on them, then I've tried to preserve a lot of the tissue towards the front where the sphincter muscles are, but they've got a wide open sort of funnel coming in from the bladder.
Very tract.
For them to pass urine. So that's a bit of a digression, but hopefully provides a bit of an overview. And also I've been talking quickly about why it's important to try and flag the early bladder symptoms that a man might have, because it's really going to be impacting upon what happens later on in life. Prostate cancer, which is the primary feature for the support group, and a lot of you will be aware of the significant impacts that we've got. 1 in 8, 1 in 9 patients will be diagnosed with prostate cancer in their lifetime. And there's lots of prominent people on both sides of politics. It doesn't really matter how wealthy you are, may end up with prostate cancer as a diagnosis. It really doesn't discriminate, and so it affects such a large number, unfortunately. And it doesn't have the same degree of media buy-in. It's not really a sexy disease, unlike breast cancer or ovarian cancer. People generally don't like to talk about prostate cancer. And what really is going to be a preventable disease for a lot of individuals if there's an appropriate screening program. Screening doesn't necessarily need to lead towards unnecessary overtreatment. Active surveillance, which we'll talk about towards the end of the talk, is the mainstay of treatment for a lot of people in Australia now, and is a way to try and avoid unnecessary overtreatment. So there's hundreds of men who will be diagnosed, or thousands of men will be diagnosed, and unfortunately thousands of men who will die of the disease each year. In general, the people who are going to be at risk and the greatest are going to be those with a positive family history. So it increases the risk somewhere between 2-fold to 10-fold if you've got a family history of prostate cancer, or if you're one of the people who have the BRCA genes. There's not so many African-American men within Australia, but patients from that background have a significantly increased risk compared to the Caucasian person. Interestingly, patients from Japan have a relatively low risk. It's about 0.8 to the 1.0 of the European male. There have been data to suggest that patients who have a PSA greater than 0.8 at the age of 40 have an increased risk of prostate cancer moving forwards. You only know that, however, if you test for it. And unfortunately, there's a number of people who will not be getting their PSA tests done. That means they're unable to risk stratify. I think it's actually going to be part and parcel of what the GPs should be doing, is to help risk stratify. They should be having those discussions with their men at 40, and they definitely should be having those discussions with men at the age of 50 once the risks of prostate cancer really start to kick in. So the one thing that we can't control is going to be age. Sure, as we're born, we will die. And as we move through that process, we will continue to age. As you age, your risk of prostate cancer increases significantly. So from the age of 50, it really starts to kick in. And actually up to about the age of 85, you're going to have, around that age bracket, about half the men will have an incidental prostate cancer. So we don't need to be too concerned about prostate cancer diagnosis amongst the octogenarian. If you've got a new diagnosis at the age of 85, 87, 88, it's unlikely that it's going to be a clinical significance for that person. But if that person is 10 to 15 years younger and they're diagnosed with the disease, that's potentially something that's going to catch up with them within their lifetime, and left untreated may rob them of years. And certainly if you're diagnosed with prostate cancer in your 50s or your 60s, then it's going to be significant, and it needs to be managed accordingly. And hopefully, an early diagnosis in that person will prevent significant long-term harms. So as I said, the known risk factors are the BRCA and BRCA genes. And these are associated with familial breast and ovarian cancers, but also has crossover into the men. So men within the BRCA family will have a significantly increased risk of early and aggressive prostate cancer. So Tiger Woods' father's famously had that mutation. Tiger Woods is going to be potentially at risk of that as well. And then you've got some relatively prominent women who've had breast and ovarian cancer. Kylie Minogue, a young breast cancer patient, is now an older breast cancer patient. Angelina Jolie, very openly with her BRCA mutation, for which she underwent a double mastectomy and then hysterectomy and oophorectomy because of the risks that she had. Male offspring from those patients would have significant risks for themselves as well, because the BRCA mutation will go across that. There are modifiable risk factors. So you can't change your genes, you can't change your age, but there are things that people can do. And this information is not really getting out there. If you look at the general community, smoking is still continuing on, and obesity is a significant problem amongst the Australian population. There's a lack of regular exercise. COVID's been its own issue for a lot of people putting on a little bit of weight, but obesity has been an issue for a number of years. A lot of my patients, unfortunately, will be quite overweight. There'll be people who we need to delay treatment for them. It doesn't really matter, if it's prostate benign disease or kidney cancers or prostate cancers, where they're not safe to have an operation until such time as we've brought their weight down. And I actually had a young woman in her 40s, I think she's 40, might even in late 30s. We needed to get her to lose weight over a 6-month period before we could safely go doing her kidney operation. Obesity is a significant issue within the Australian population. Alcohol is its own issue, and essentially every unit of alcohol a person drinks, that's going to be one shot or one standard drink, increases somebody's risk of cancer by about 10% for all causes. And so people who like a beer a day or a glass of wine a day, that's a 10% increased risk that person's taken on. If people like 3 or 4 beers, often the beer is going to be 1.2 standard drinks. They're essentially taking on a 50% increase in risk from their alcohol intake, and that's a significant, modifiable, thing that some people can do. People who have a higher body weight, so the BMI is the body mass index, and as people have that BMI start to increase, there's a significant increased risk for those patients of dying from prostate cancer. So, BMI of 18 to 25, 18 is actually a little bit low, but 20 to 25 is considered to be normal. And depending on how wide people's shoulders are, there's going to be a little bit of variation around this. The BMI is not a great tool, but it's the best we've got. So assuming that you've got the 20 to 25 range, there's a relative risk of 1. Once you go up to that 25 to 30, that's somebody who's in the overweight category, they're taking on a 10% increased risk. Once you go over 30 and you start to become somebody who is truly obese, then they've got a 20% increased risk of prostate cancer death. If they're over 35, your BMI, then they've got morbid obesity and they've got a 30% increased risk of death, not just all causes, but death from prostate cancer. So being overweight, the fat tissue itself increases how aggressive somebody's prostate cancer is, will increase the probability that they will die from their disease. Unfortunately, I don't have a map like this for Australia, but if you look at what was happening within the United States in 1990, and the United States has historically been an obese country, they had about 10 to 15% of their population was considered to be overweight in 1990. Move forward, 30 odd years, and 25% or more of the population is going to be in the obese category. That's BMIs greater than 30. Australia, unfortunately, has a higher rate of obesity than the United States. So for all the characterization that happens about the US being this morbidly obese population, Australia is worse. And so, we have a very high alcohol intake, and we like our fatty foods. We're not exercising anywhere near enough. We're eating the wrong foods. Sugar, intake is bad, and people are suffering as a consequence of that. Any questions so far as we're moving through?
You had ETOH, and you said it was alcohol.
Sorry, ETOH is alcohol.
Oh, okay.
ETOH is ethanol. Sorry, it's it's the medical abbreviation for ethanol. I'm sorry about that.
Thank you. That's fine.
So the PSA, which this is basically the mainstay of the screening test. So the PSA is still not all that understood as to what it is. People know they're having a PSA test. The PSA is a protein, so it's the prostate-specific antigen, or the prostate serum antigen. It's found in the serum, but it's also found within the prostate. It is a normal part of the prostate. It's a liquefactive enzyme which dissolves mucus. So it comes out with the ejaculate and is part of reproduction. It's found in all prostate glands, not just the cancerous ones. it leaks out into the bloodstream. So like liver function tests, you can see what's going on with the liver by measuring the blood. You can see what's going on in the prostate by measuring the blood as well. So this PSA, the enzyme, will leak out from the prostate into very small levels into the blood, and you can see what the readings are. The PSA will leak out from the prostate at higher rates if there's inflammation going on. So people who have difficulties passing urine, people who have infections, people who have bladder stones, their PSAs will be pushed out. But if people have prostate cancer, then the PSA is going to be pushed up as well. So the prostate is quite leaky for people who have prostate cancer. The cells are just not normal cells. So the PSA leaks out and you can have quite high readings. With BPH, or the benign enlargement, the glands are bigger. It's like having a bigger factory. There's more cells. And so more PSA generally tends to be right as well. And so you can see higher PSA readings for people who have very large prostate volumes. At the same token, that same concept applies to people with prostate cancer. So people with prostate cancer, as the cancers are making this PSA, as the volume of cancer cells increases, that has an impact upon what's happening with regards to their PSA levels as well. So if you have a man with known prostate cancer whose PSA was, say, 10, and then that PSA has gone from 10 to 20, the implication of that is that their overall number of cancer cells has doubled. If you have a person whose PSA has gone from 300 to 600, implication is that their overall volume of active cancer cells has also doubled as well. So it's a very sensitive tumor marker, so we can see biologically what's happening. We don't need to do scans because we can measure their PSA and see on a blood test what's happening. Now, the role of PSA testing is still something, unfortunately, that is debated. As there's been much debated in the community about whether or not we should be doing PSA testing, PSA screening. The Cancer Council has a pretty good position paper on that. The Urological Society made out a position statement. There was the Melbourne Consensus that came out 2013, I think it was. Basically, everyone is in unanimous support that there is a role for prostate cancer prevention. There's a role for prostate cancer screening. The PSA is the best tool that we've got for that. Unfortunately, the College of GPs is protective of their GPs and is not advocated for that as yet. The reasons behind that are not entirely clear, but they don't gel with the advice of the oncologists. I think part of the role and part of the reason is that the GPs have, at a central level, have tried to avoid the unnecessary harms of over-treatment of prostate cancer. Certainly overseas, there was quite a bit of, I'm talking about the US, quite a bit of over-treatment of relatively mild prostate cancer that was happening. But as we've shifted towards more accurate diagnoses, we're minimizing with MRIs and otherwise, we're minimizing the need for unnecessary biopsies to be done. And additionally, for people that get a diagnosis, we're far better at trying to work out those people who have aggressive tumors versus non-aggressive. And we're also able to direct a lot of patients now towards a safe active surveillance program where we minimize the need for over-treatment. There's a misconception, so I'll just back this is important. There's a misconception that all PSA tests are the same. The reality is there's actually a huge amount of variation from one laboratory to another. And so they're really not all the same. It's important that people continue to try and get PSA testing at the same laboratory. Historically, the Douglas Hanly Moyer or Sonic Healthcare assay had been the default assay, had been the more accurate assay. There'd actually been up to about a 30% degree of variation between the different tests. What that means is that you had somebody in the community whose PSA was being checked and was nominally seen to be 2.5 or so. That PSA reading of 2.5 could actually be a PSA closer to about 4. Means a person with a PSA of 4 could actually have a PSA closer to about 6. Because the older style, I won't mention the laboratories, but the labs that they've been using, the assay just wasn't necessarily all that accurate. And everything as of the last year or so seems to have largely standardized towards the more accurate testing, which DHM has been using for the longest period of time. And that's the preferred assay that we should be using. So if we standardize amongst that, then we'll get much more accurate assessment. If you've been using assays at other laboratories, then for ongoing monitoring, it's going to be important to try and keep on, where possible, using that same assay, because you'll be able to at least be comparing apples with apples as opposed to jumping across it. One of the potential failures about this different degree of testing that's been done historically was that it made it difficult to truly give a person a better understanding upon what their risks was, and also meant people who had biochemical recurrence after treatment, you potentially would have a failure to detect those patients because you just weren't getting the things done early enough. The PSA testing and the thresholds of what's considered to be normal. Historically, there have been some suggestions that a PSA less than 4 was safe and greater than 4 was considered to be pathological, and that's really not the case. The median PSA at all ages is going to be below 1.6. So there's going to be quite a degree of ranges of PSAs, what the standard deviation is around the median, but at all ages, the PSA should be less than 1.5, 1.6. The age of 40, the PSA is going to be about 1 or so. As the person gets older, once the person is sitting in their 70s, the PSA should be about 1.5 or so. For this hypothetical patient, PSA has just been slowly rising, if you would, over the last several years. So PSAs are moving up, and people think, despite what I just said about what the median is, a lot of people who've been recording these PSAs at the community level, unfortunately, because it hasn't yet reached the threshold where you get the little red flag on the right-hand side of the PSA reference ranges, because not above the nominal number of standard deviations to be abnormal, it doesn't become bold. So the GPs aren't twigged to it, and the patients aren't reading it. People are not seeing that there's an upwards trend, but there's a clear upwards trend happening here. And the answer is yes, this person could have prostate cancer. About a decade or so ago, when I was at the research fellow at the Kinghorn Cancer Centre in the Garvan, we looked at the number of patients who were having prostatectomies. So it was a self-selected proportion of men who had prostate cancer, but a large number of these patients had actually quite aggressive prostate cancer, despite their PSAs all being below 4. Essentially, of these people with PSAs less than 4 who ended up having surgery, about 60% of them, 2/3 had actually aggressive disease. They had intermediate risk disease. They had about half of them were either going to be locally advanced or pushing into the seminal vesicles. It's a significant number of patients who had quite significant disease. Shall I stop there for now? Any questions while we're moving through? Hello.
Yeah, we're here. Any
Okay.
questions, anyone?
No questions.
Okay. So I mentioned before about family history. You don't always have to end up like your father. That's the Darth Vader reference here. So this is a chap only from actually this month that I've seen, who's 60, roughly 60. I'm trying to change some features, but essentially he's 60, who's been referred into me with a PSA of 3.9. He's only just, unfortunately, started his surveillance. So his father was diagnosed with prostate cancer when he presented with a PSA well over 1,000. So this chap, who has a very strong family history in his father with presentation with late stage disease, unfortunately, he's only presenting with a PSA, PSA of 3.9, but he's had an MRI done on the basis of that, and his prostate feels a little bit firm. He's got disease extending outside his prostate. Unfortunately, this is somebody who ideally would have caught a little bit earlier. So this is the MRI for this individual. And can you see my mouse moving there?
Yes.
And what we have here, so these are his pictures from last week and from the SAN radiology. And so we have the bladder over here and the prostate below. That's the phallus going out. But what we have is the seminal vesicles. This is this little gland that sits at the back. And that is a tongue of tumor extending into the seminal vesicle. So he's got locally invasive prostate cancer, despite only being PSA of 3.9. Low PSAs are a risk for these individuals if the trend is onwards and upwards. So this person, has a wide circumferential little rim of tumor the whole way round. All that black area should be white. He's got tumor the whole way round the underside of his prostate. So that's the rectum, so you can feel it through there. The whole underside is involved, and it's pushing up and into the seminal vesicle. His PSA is still only quite low, but it's lighting up. It's lighting up. These are pictures that we moved through. Now, case study number 2. So this is from last year in the middle of COVID. Another referral to me. So the patient's GP referred him in. He was 58. The patient came and spoke to the GP because he had some urinary symptoms. It's a good GP. The GP has said, look, patient X, your urinary symptoms are unlikely related to your prostate cancer. Let's check you out. Has examined the man's prostate. He's got a palpable little pea-sized lump in the prostate, and organized to get his MRI scan. And sure enough, we have a little palpable pea-sized lump sitting there with the arrows going onto it. And this is his biopsy, which I've done on it. His PSA was only 2.0, but he has grade group 5 prostate cancer. So it's an early detection, and that man has continued to do well. Essentially, he's got aggressive prostate cancer, caught early, confined to a small area at the underside of his prostate. PSA was only 2. Had that been allowed to progress from a PSA of 2, it would have been a relatively quick upswing. Had he not had examination and testing, it would have been missed. If you have a look at his reference ranges for this particular patient, you can see that all of his PSAs have been at the relatively low range. So they're going from the 1 only up to 2. So at an individual level, the PSAs are still low. The reference range on the right-hand side is what the laboratory is giving him as the normal reference range for his age, based upon what the normal standard deviations are. Unfortunately, the computer software isn't able to really see or report upon the significant PSA velocity. So the total PSA has less bearing at a screening level than what the rate of change of the PSA is over time. And so the PSA velocity, or the PSA doubling time, is really what is going to be important. We can see that this person's got onwards and upwards growth of that PSA over the last several years before it really starts to hit a threshold where the GP is not, look, we should do something about this. PSA screening trials have been done over the years, and it's got onward follow-up that's happening. The ERSPC is one of the better ones, and we've got long-term follow-up going on now, going out to about 20 years. I think the pictures are from 14 years ago. Essentially, what it's showing is that the cumulative incidence of prostate cancer increases. As you start moving on to about 14 years or so, there's a significant reduction in the rates of significant prostate cancer if you detect these people and treat them at an earlier stage. For about 10 years or so, there's not much in the way of overall benefit for patients. But once you get beyond that, then you significantly decrease the mortality for patients. And that makes sense. If you look at the biology of prostate cancer is a slow-moving disease for most patients. And so, treating, Gleason 7 prostate cancer on somebody whose life expectancy is less than 10 years, it's unlikely that that's going to significantly alter what's going on for that person in the future. If somebody has aggressive prostate cancer, it needs treatment. If somebody doesn't have a long life expectancy moving forwards, then you don't need to go detecting it. And that falls back to what I was saying earlier about the 85-year-old. The 85-year-old, we don't need to do things that might have an impact upon where they're going to be 14 years from now, because they'll be 89. So that they'll be 99. They'll be getting their letter from Queen Camilla at that stage. So you don't need to be doing things necessarily impact upon the late life, but you need to be doing things that will impact upon people who have a good degree of quality and quantity of life for them moving forwards. And so there's these follow-up trials. So this is from a couple of years ago, this paper, when they were looking at 16 years follow-up. And what they were showing is that you need to screen about 570 patients to diagnose 18 patients to then save one person's life. And that's going to be better than what we're getting with breast cancer. And that's just commencing the screening process with a PSA. you can only really continue to follow this up at a community level if you do serial PSA testing. And so one of the arguments about not doing PSA testing is that you may find these potentially low risk cancers that will be treated inadvertently, and or you'd have false positives come into play. You'd have a person with one-off PSA that's elevated, and that would then direct somebody towards an unnecessary biopsy. The suggestion was then that GPs should practice a shared decision-making model, which means that patients at an individual level, they should sit down and discuss about the relevant pros and cons of screening with all male patients from the age of 50 to 70 before doing PSA tests. And that's a noble position statement, but unfortunately, I suspect it misses the time pressures that people have, particularly during COVID, where there's really short-staffed everywhere. Where it's going to be a time-consuming process. It's very hard to provide patient education. It's hard to provide patient education in a bulk billing practice, where the only way to keep the practices going is to have high turnover. And so it's going to be easier not to go doing, and more practical, not to go doing testing, or at least not having that discussion. And the decision to do it or not will rest purely upon the clinician rather than patients having an open discussion with their GPs. My thought is that we should screen, and we should have screening with a PSA test followed up with a rectal examination. It's important because a lot of these cancers will have a relatively normal PSA, so to speak, normal like that patient beforehand whose PSA was normal at 2, but had a clearly abnormal rectal examination. If the GP hadn't stuck a finger and examined it, then he would have missed it. So the rectal examination will save that man's life. And unfortunately, it is an invasive and it's a little bit uncomfortable, and some people feel quite a bit of anxiety about the whole process of having examinations done. Hopefully, we're going to decrease the likelihood of false positives from PSAs moving forwards by doing MRIs as a precursor to most biopsies. In Australia, it's become standard of care that patients will get an MRI before their prostate biopsy. The government's finally recognised that, so there's a MBS item number that's come through several years ago to help support that, so that patients have low or virtually no cost MRIs before their prostate biopsies. It also helps to minimise the need for prostate biopsies if their MRIs are very low risk. Interestingly, in the United States, which is still the biggest market, if you will do, where a lot of things are published from, only about a third of patients over there will get an MRI before they have a prostate biopsy as of 2022. So Australia is doing a lot better than what's happening overseas. But unfortunately, we're a relatively small market. And so and we don't have a large population to publish from. So as a consequence, the literature doesn't really flow from us, anywhere the same level that it does from the academic institutions overseas. We can use modifications of the PSA to try and look about risks, and the Fred-to-total ratio comes into play. You might have seen that discussed previously. As a general rule, higher is better. It's more reassuring. Lower is worse. It's really only validated, however, if the ratio is between the overall levels are between 4 to 10. So if the totals are between 4 and 10, then there's going to be some degree of accuracy to this as a manipulation of the PSA. If it's outside those reference ranges, then you can't go using it. Essentially, it's something that I look at and I take it with a grain of salt. More important than what the actual Fred-to-total ratio is going to be what the PSA velocity is. So, as I was saying before, as the PSA changes with age, then you expect a little bit of a drift upwards. But if you see a person's PSA starts to grow exponentially, they've got a high velocity, that's a significant concern for me. This graphic on the right comes from the Douglas Hanley Moyer website. They've got a really great information sheet, which if you just do in Google DHM and PSA, this will come up as a PDF, as a GP-facing worksheet that you can read through. But it's got this really nice little infographic which gives the table of what the median is at all levels and what the rough reference ranges are. Those reference ranges are what the standard deviations are for that 95% of the population. And as you can see, the reference ranges start to broaden as a person ages, but the median always stays below 2. And actually, really, it should be below about 1.6 for the 80-year-olds. But yeah, except that the median should be below 2. It becomes a bit concerning when you see people not referred in to see somebody, a urologist or otherwise, unless the PSAs are hitting that greater than 95% reference range. And so they're not nominally in the high risk until they're in that top 5%. But maybe the reference ranges that the labs are reporting should be putting the cutoff at 75%, so that you're capturing people, once the velocities are really starting to increase, at a lower level. And so the PSA velocity, as I said, is something that, is what I look at. There's multiple potential different patients here. For these artificial, level that I've made of 3, they've all got the same total PSA as of June 2020. However, they've got them there by different points. So patient 1, his PSA is not really changing. It's just a bit undulating, like ripples in the ocean. He's probably just got a bigger prostate. Patient number 2, he's had relatively linear type of PSA growth going on over the last couple of years. That's something that needs to be followed up with. The patient number 3, who's had relatively significant changes in the PSA over the last couple of years, is suggestive of a rapidly growing tumor, not quite metastatic, because it's not a PSA that's really high, but it's a rapidly growing tumor until proven otherwise, and that needs appropriate investigation despite the low overall PSA. So as a general rule, you shouldn't hopefully be fearful patient on the right-hand side, or the community level at least. Patients should be having regular PSA tests. They need to see what the trend is, and if it's high, you investigate appropriately. As I said before, the Cancer Council's got some really good guidelines. This is the link to it there, which you'll hopefully see in the video later on. But it runs through the Cancer Council's advice testing strategies, and how this should be done moving forwards, and the frequency that we should be doing it. To complement some of this, there's a role for doing MRIs. So the MRI, we talk about this multi-parametric MRI. Multi-parametric is really just a bit of a buzzword. What it means is that not just a single scan in and out of the tunnel, but we're doing some additional modifications of the MRI to get some better understanding upon what's happening in regards to the biology or the vascularity of these patients as well. So you're in the scanner for about 45 minutes. The classification system that we use is called the PIRADS classification system, and essentially it becomes a probability scale. So it gives us a score of 1 to 5, which really talks about how aggressive these potential areas of interest on the scans are, and whether these are things that we would be happy to watch for the category 1 to 2. If it's intermediate risk, we might consider a prostate biopsy. And if it's a 4 or 5, we really should be talking about doing prostate biopsies in these individuals, because they're much more likely to be prostate tumors. So these are some potential prostate tumors, and we can see with the T there's a little bit of blurring of the margin, the capsule around the prostate, and that's where there's going to be some invasion going through. We can start to use some computer software to help assist with our MRIs and do some MRI fusions. And so what we can then do is allow for the markup of the MRI before the biopsy to then give a true X marks the spot, so that in real time, when you're guiding an ultrasound probe in the rectum, you can use that ultrasound probe to correlate with the MRI to be certain that the needle that you're putting in the prostate is going to the spot where the MRI says it should be, and increases your diagnostic accuracy of the biopsy. It means that there's going to be a low incidence of false negatives, and immediately unlikely to miss the tumor, and also decreases the number of needles required. So it becomes a less painful biopsy experience for patients, less risk of blood in the urine, and difficulties passing urine afterwards from swelling. The PSMA PET is something that you may or may not be overly familiar with. I wrote an article about it for the SAN Doctor several years ago, which will be within the resources that the SAN has. So about 4 years ago, actually, now it looks like from there. The PSMA PET scan is something that is a relatively new technology, looking at using the prostate-specific membrane antigen tracer to help link on to aggressive prostate cancer cells, and then it lights up within the prostate. The role for the PSMA PET scan is to, at the moment, go looking for patients who have new diagnoses of prostate cancer in the staging system, and also for people who have recurrent disease after they've had treatment, and you're looking to see, because the PSA is starting to rise again, where these spots might be. However, there's significant synergy between MRIs and PET scans. And as we move into the future, there's going to be an increasing number of patients who will have a MRI and a PET scan pre-biopsy. There's been a trial which we've recently run at the SAN, the MP4 trial, which was looking at using the PET scan pre-biopsy to both help guide the biopsies and may also serve in the future for patients who, we may end up in a scenario where we can, for patients who have a suspicion of prostate cancer, have an MRI, have a PET scan, and we avoid the need for biopsy altogether. Much as what happens for people who have kidney tumors, or brain tumors. People have lesions that look abnormal in the brain on MRI or CT, and they can have their treatment plans arise from that. You don't need to go doing a biopsy first. You just need to treat the underlying tumor. And that's probably going to be the direction that we're heading in. We're just not quite there yet. We need to get justification, to do that it's safe and accurate once we have, more robust studies. But certainly the SANS publication, which we've got coming out, is pretty convincing. At St Vincent's, I'm involved with another trial at the moment, which is looking at the use of the PSMA PET scans in active surveillance. So it's called the PIAS trial, PIAS, which is where we're using the PET scans, PSMA PET scans, for people who have low to intermediate risk disease. And we're looking to see if that will help pick up additional sites of tumor or give us reassurance that ongoing active surveillance is going to be safe for those individuals, that we're not missing things. At the moment, we're not quite there yet. The evidence is not there, and that's why we're running the trials. So the PSMA, it's this promising target in about 85% of the prostate cancers, but particularly the prostate cancers that we need to worry about. So it's got an increased number of receptors of the PSMA for patients who have these aggressive cancers. It generally doesn't tend to be all that upregulated for patients who have relatively indolent, low-risk cancers. If your PSMA scan is positive, it's a bit of a poor prognostic indicator because it suggests that that tumor's got more aggressive characteristics. But if it's confined to the prostate with nowhere spread beyond it, then hopefully what the suggestion is that we've got an early capture of this cancer. We can treat it, and we will be happy that there's no sign of any lymph node spread beyond that. If the PSMA scan is negative, there's two possibilities. One is that it may be a low-risk cancer, which is a good thing. It just hasn't got enough PSMA receptors to be lighting up. The alternative is that it may be a really aggressive type of prostate cancer. It may be late stage, which is de-differentiated and no longer look like prostate cells at all. Or it may be a variant, a ductal or some other sort of form that's not taking up the PSMA tracer just because it's an aggressive sort of thing. This is what the PSMA spots look like. So this is a person who has a PSMA PET CT where they've got some hot spots within the prostate, and then they've got lymph nodes lighting up within the pelvis. And without those, the PET lighting up in those spots, you wouldn't necessarily know that those were anything other than a shade of grey. So this patient, we have what was hoping to be organ-confined disease, which unfortunately has spread into lymph nodes, and that changes how we might need to go treating that person into the future. So the PSMA, I should say, scan, however, if we use it with an MRI, adds a little bit of molecular information to the MRI. It will help to complement it. It helps to find some suspicious lesions that are outside the MRI ones that we can target. And we can also use it on a surveillance pathway or otherwise if you still think that somebody might have prostate cancer that you're missing. The PSMA has advantages above and beyond standard CT scans because you've got lighting up, so to speak, where you otherwise would miss things. So this is a bone spot on this patient. So you can have an arrow pointing to a clear PSMA-avid hotspot within that person's vertebra. Traditional CT scan, there's no evidence of that at all. That person has then been able to go on and have some targeted radiotherapy to that, and you repeat the scans afterwards, and that spot's disappeared. So it's a way of helping to direct treatment as well as improving the diagnostic side of things. We're using that as the preferred primary staging at the moment. We're using it to find recurrent prostate cancer. As of 2022, or July 2022, so I'm talking about a couple of weeks ago, There is now a rebate attached to things. Historically, patients would have to pay out of pocket for a PET scan. There's now finally government recognition of the utility for it, and patients within those two unique scenarios, we can get rebates for it. Active surveillance or to help with biopsies, there's no rebate for that as yet. We need to wait for more robust evidence to help support it and the MBS to come through. For this patient, this is a 65-year-old person who's had a traditional bone scan, and this is what their PET scan looks like. There's quite significant difference in what the degree of tumor uptake is like. This is the same person, the same cancer, same point in time. One scan is clearly more accurate and better represents the tumor load on that individual. Hopefully, as we move to the future, we'll get better tailored outcomes for these patients, and we'll get a wider range of patients that we can do. This is actually what a PSMA MRI fusion looks like, where we've got hotspots within the prostate. Unfortunately for that patient, we've also got a few hotspots within his pelvis as well. On this imaging over here, we have, I've lost my mouse, interestingly. So we have the top right-hand side, we've got the MRI scan of the prostate, and there's that very black spot down towards the right part of the prostate. When we put the PET scan overlay, there's a red spot which is congruent, meaning it lines up, and that's going to be indicative of a PSMA avid, meaning taking up PSMA prostate cancer. That means that the tumors that might have spread from that, any metastasis, should also be PSMA avid. Helps with the treatment planning. Okay, we move through, and this is going to be what it's. Sorry, this is an interesting patient as well. So this is a patient who has MRI at a young age, which was relatively normal, but he has a PET scan, which is showing a large PSMA avid central tumor. The prostate's got quite a bit of different anatomy, and the central zone, or the transition zone, historically has been quite hard to image on a MRI scan. The PET scan doesn't have the same issues, and this person has a MRI which is otherwise miss their prostate cancer, but it lights up in a relatively obvious fashion when you go doing their PET scan. And that's something that we can then go targeting for treatment for that individual. Now, I think we're moving forwards. Okay, good. So we're back up to the publications from the pivot trial and the Preventative Services Task Force. Unfortunately, there's been some clouding with regards to the role of PSA testing and PSA surveillance. A lot of you all heard about the US suggestions that you shouldn't go down the path of doing PSA testing because it didn't save lives. This was when the US the US PSTF, which is the Preventative Services Task Force, went through a group of Veterans Affairs plans who all had significant comorbidities. And unfortunately, it's not looking at a general population. It's looking at the people who had a very poor prognosis. They were dying at a much higher rate than what's happening within the general population. Because they were dying at a much higher rate than the general population, we've already seen from the European study, which is a general population study, that it takes about 10 years to start to see survival advantages. It's not really surprising that if you only follow these men up for a relatively short period of time, and a lot of them are dying anyway, then the PSA test is not going to save lives. Despite that, if you follow these people up, what we're then seeing is that there's been an increasing incidence then, in the States, there's been a shift in what they've been doing, an increasing incidence, unfortunately, for late stage prostate cancer. So they were decreasing how many men they're diagnosing with local stage cancers after these changing guidelines came into effect, and increasing incidence of late stage cancers. What it's meant is that the US PSTF's recommendation was put into effect. Less PSA testing was happening. Cancers were being missed. People were not being diagnosed when it's still confined to their prostate. As a consequence, they're then being diagnosed with metastatic disease. And we're starting to see this in Australia as well, unfortunately. So these are some additional patients to come through who are my patients who have had lapses in their PSA testing. This is a person who, at 2015, his PSA was 8.1. For reasons unbeknown, he'd never had any follow-up from that until 2019, when his PSA was 120. And so we can see here this individual's PET scan with lots of lymph nodes lighting up throughout his retroperitoneum. He's got a relatively small spot within his prostate, which is then jump shipped into the lymph nodes and into the bone. This is another patient who's presented with bone pain, and that's what his PET scan looks like. So again, his PSA in 2013 was 5.9. It was measured in 2007, 2016 when it was 7. Nothing was done about it at that stage. We moved forward 3 years and it's gone from PSA of 7 to 1250. So he would have had prostate cancer slowly brewing between 2013 and 16. The PSA was rising. It was confined within his prostate, and very quickly it's gone from being an organ confined to a widely metastatic disease and incurable. And at that stage, by the time you do your biopsy, he's got very aggressive grade group 5 disease. Another individual who unfortunately had a few marital issues. So he was having his PSA done. Again, it was rising, 3.7, 4.5, 5.4. And then for one reason or another, didn't have the PSA checked in 2019. And then 2020, the PSA has gone up to 50. I've double checked it to validate it, and it had gone up to 64. And so essentially the rise from 5.4 to 49 took 21 months. The rise from 49 to 64 took 20 days. The prostate cancer, when it really starts to spread, It's one of the reasons why if we're going to catch things, we want to try and catch it when it's small and organ confined. Another one, this is just my personal case series. These are not cherry picked. So this is PSA in 2018 when it was 3.3. A couple of years ago, has come to see me, and his PSA has gone up to 200. Again, that rise from 3 to 200 took only 30 months, not a long period of time. We've checked it again less than a month later, it's gone up to 210. Relatively rapid rises. In the old days, people were having transrectal prostate biopsies, which meant having biopsies done up through the back passage, which actually is still how about 60 or 70% of US biopsies are done. And it was done because it was relatively cheap and cheerful, and was the most straightforward route into the prostate. But unfortunately, it's painful for the patients and associated with significant risks of infection attached to it. That's probably one of the reasons as well, whilst there's been a suggestion historically to avoid doing screening for prostate cancer, because the actual investigations themselves could be just as problematic as the treatment. About a decade or so ago, I wrote a paper, which was at the time the largest series of transperineal prostate biopsy patients in the world. So we had 409 patients, which we followed up. We became the BJUI's, the British Journal of Urology's paper of the week. And what we were able to show is that for these patients with a transperineal prostate biopsy, the rate of complication was significantly lower. And I compared it to the Urological Society of Australia's audits that were done on prostate biopsy. They had some contemporary biopsies audits in 2005 and 2007, and our rate of infection was significantly less. Rather than something that was closer to about 5% of patients who are having prostate infections potentially, we ended up, because we're no longer putting these needles through the feces, we had one infection amongst that 409. There's been publications published since which have infection rates about 1 in 1,000 or so. So it's a very safe biopsy technique compared to the 1 in 5 patients who end up with serious sepsis sort of infections. So we've since written that up in the Urological Bible, which is called Symons, where I've written up the technique, and it's now become a much more widely practiced biopsy technique. It's certainly how the majority of prostate biopsies are done in Australia and in Europe as well. Unfortunately, the United States, because of its health system, is still tending to favour the transrectal approach. Any questions so far?
No, it's. I guess there's a lot to take away from everything you've been talking about, Dr. Symons. One thing, I guess, just to try and summarise, is it's when we're talking to our friends about getting tested and we're talking to them about their PSA. What's sort of the trigger? 1.6 or thereabouts seems to be the median, probably for people in my age. What do I say? Look, if your PSA has risen 3 times in the space of a year, or do I say,
if it's risen 3 times in the space of a year, then
no, in 3 years, let's say.
If it's risen 3 times in the space of threefold in the space of 3 years, that's a significant rate of rise. Significant rate of rise. Essentially, if it's rising by more than 1 nanogram per mil per annum, that is a significant finding. So if the PSA has gone from 2 to 3 to 4 over the space of 2 years, that's a doubling over 48 months. That's a significant concern. If the PSA is rising by 2 nanograms per mil per year, that is a huge red flag. Say it's gone from 3 to 5 to 7, then that's associated with very aggressive prostate cancers and poor outcomes for patients. Unfortunately, what I saw before for some of those other patients were people with things that ideally shouldn't happen. They're the never-nevers, because they're the ones that have come to me that I've seen who have had PSAs in the thousands or the hundreds, who actually, if you look back at their trajectory, they had PSAs that were in the 5s, 7s, 8s, 9s or things that nothing was done about for reasons that I don't know. I can't really comment upon what was happening in the past, but somebody has requested that PSA, somebody's checked it or tested it but not checked it. Something's happened. So they were sort of having default. The patients thought they were doing the right thing, but unfortunately, whoever's requested it didn't follow it through. I think it's important for people to have some degree of bodily autonomy and take responsibility for their own health. People tend to have a good understanding upon what their blood pressure should be. For reasons that make no sense to me, people really want to know what their blood type is, even though it's got absolutely no bearing upon anything. People love to know if they're O negative or AB positive. Who cares? Doesn't make any. Never get tested unless you're having a blood transfusion. People want to know that sort of stuff. People sort of want to know what their blood pressure is, which makes sense. You want to know that you don't have a really high systolic blood pressure. But it's reasonable that men who are health conscious would know what their PSA is and would understand that if that PSA is rising, that's something that needs to have a discussion about it.
Right. So the message is, if it's rising at all, year on year,
if it's rising, then follow it up. So have a discussion about why it is. Get an ultrasound. Unfortunately, the GPs can't request MRI, so although they can, but there's no rebate attached to those, so people will pay out of pocket for it. If a urologist or a radiation oncologist requests a PSA and they hit the criteria that Medicare has, then you'll get a rebate towards that. You need to make sure you're getting a good quality MRI. They're not all the same. But if your PSA is rising, start the conversation. Start the conversation. And if you're a person who actually is health conscious, and most people should be, then it'll be prudent to start having PSA testing from the age of 50 every year to 2 years thereafter. So the sweet spot would seem to be doing a PSA test every 18 months from an overall cost to society versus a minimization of harms of overtreatment, and also not missing cancers perspective. 18 months is the spot, but it's quite hard to timetable things every 18 months. People generally will just do it every year. People will be coming back to see their GP every July. They just know they get a mid-year checkup, whatever it happens to be. It's very hard to know that you're going to see the GP in July this year and January next year for your mid-year well-mail check.
For someone who's monitoring their PSA levels, like I have 6 months monitoring. Like, what would be a concern if, like, how much rise in PSA would 6 month would it cause concern if I was having scans every 6 months?
You wouldn't be having scans every 6 months. You could be doing tests every 6 months.
PSA test. Sorry, yes.
Do you have prostate cancer or not?
Yes, I have one. I'm under active surveillance.
Oh, look, if you're under active surveillance, then having PSA testing every 6 months will be covered by Medicare. And so long as it's all staying around the same ballpark, it's not got rapid rates of rise attached to it, you're fine. If it's starting to rise by 1 or 2 nanograms per mil every year, that becomes a bit of a red flag.
When you say 1 or 2 nanograms, it's not like in the in the result sheet, or in the result sheet, it's like 0.0. Like
Yes.
it's
So when it says 0.1 or 1.2, what that's recording is 1.2 nanograms per mil. The alternative is that they might be recording micrograms per deciliter, but the general terminology we use is going to be nanograms per mil.
so if it's like from 4.6 to 5.6, that's 1, is it?
4.6 to 5.6 is a rise of 1, yes.
Right. Okay.
Which in and of itself may not mean anything, because there's, at the end of the day, most men with prostate cancer will have, if I look at a man I had, earlier today whose PSAs were 12 and then 10 and then down to 9 or something, that's a reassuring. His PSAs have come down. The driving force behind his PSA is not his, that's not his prostate cancer. It's going to be his BPH. And that comes back to what I was saying earlier, in that at the end of the day, men with prostate cancer are men with a prostate. So there's plenty of men who have, benign symptoms that we can't overlook as well. So, the driving force behind the PSAs for these people with large prostates is going to be a large prostate. They've got relatively low risk prostate cancer that's not really doing too much for them. No harm for them. And so the impact from the PSA for those people is going to be relatively low.
Dr. Symons, you've got more to come. I'm just thinking at the time.
I have more, some of which I've already discussed on. So I've got some duplication, which we can jump through from here. So let me jump forward a little bit to the US PTF and pivot. So we need to jump forward to here, which is prostate cancer treatment. Okay. So we need to come to here, which is where the focus of things, for a lot of people is going to be. So prostate cancer treatment is treating obviously the newly diagnosed prostate cancer. For patients, I like to draw this little flow sheet for patients when they come to see me. We have a new diagnosis. So for people that come to see me with a clinical suspicion of prostate cancer from their GP based on a PSA that's slightly high, I then will go down the path of getting an MRI scan. We'll do a rectal examination. We confirm the diagnosis. So we get a grade, which is the tissue diagnosis. Once they've got that, or even sometimes before they've got that clinical suspicion, they want to jump through straight to the end. They don't want to be the start of the story. They don't want to read the chapters in the middle. They want to get to the conclusion and then already close the book. Unfortunately, we don't just jump into the treatment options and the follow-up thereafter until such time as we've gone through the motions. And those motions include getting the grade and then the stage, which is going to be this scan. So it's going to be the PSMA PET scan, or historically it was a CT and a bone scan. Once we've got the scans done, then we go down the path of doing the treatment options, which we generally will be individually tailored to the patient's needs and also their tumor type. Patients who have aggressive prostate cancers need more aggressive treatment. Patients who need or have less aggressive cancers, as a general principle, have less aggressive less aggressive treatments. The Gleason score has been replaced years ago now by the grade group score. Grade group 1 is low risk, grade group 5 is high risk. As a general rule, patients with grade group 1 we will put under active surveillance. Patients with grade group 2 could go into active surveillance if it's low volume Gleason 7, or onto curative intent if they've got moderate volume or higher PSA, something that looks suspicious about them. If they've got significant disease, they need significant treatment. Patients who have grade group 3, there's no question they need curative intent. They're not safe for surveillance. Patients with grade group 4, that's going to be the old Gleason 8s, or the grade group 5s, which is the 4+5 or 5+5, or the Gleason 10s. They need curative intent, and they're the sort of people that you throw the kitchen sink at. They often need a multimodal treatment. Curative intent is a terminology, which is where we essentially are pursuing cure. Prostate cancer, like all cancers, it's not a binary thing. People love the idea of cure. Unfortunately, you can't really say cure until you've gone down many years from now. It's one of the problems with some of the studies that looks at short-term cancer outcomes. It's very good to make somebody look cancer-free at 3 months. And I've seen letters from less scrupulous individuals where they say, "Look, Joe Bloggs is great. I've done the operation on them, and here they are at 6 weeks, and their PSA is 0. They're cured." No, they're not. I mean, they might have had a good operation. It's great that the PSAs come down, and it's what we all strive for. But they're not really cured. We've gone in with curative intent. what we really need to do is then monitor them, and they're in remission. So unfortunately, remission sounds more like shades of grey, but life is about shades of grey. But we're going with curative intent. It doesn't mean that the treatment is any less worthwhile, but the idea is that we go in, we try and do our best for the individual. It's a struggle for people with the uncertainty about this, and it's hard for people to follow on, and do the follow up. And they always want to know that they're doing well. When we go through with curative intent, we're essentially going through with either surgery or radiotherapy or a multimodal approach. These are the aggressive tumors that will need potentially surgery, radiotherapy, and androgen manipulation, and or clinical trial involvements, and or potential enrollment in use of some chemotherapy for really high risk people. What we're really looking at doing is shifting the goals. As I said, so the survival for patients is something that we're going to try and push so far into the future that they're going to live a long life. And if they can outlive their prostate cancer is going to take 20 years to kill them, but you can get them, their natural lifespan is going to be 15 years because they've got other things going on. Then it makes more treatment. What was that? Sorry.
If you're just listening, if you could go on mute, that'd be great. Thank you.
Okay, so essentially what I'm saying, the aim is to try and shift things into, shift your treatment goals into something that's going to be a chronic disease picture. So it's going to be something that we can then monitor into the future and use additional treatment options as we need to. Active surveillance is the mainstay of treatment, actually. And this is one of the things that I think the guidelines don't yet fully take into account, is that about 70% of patients with a new diagnosis of prostate cancer in Australia will end up on surveillance. So we are not going down the path of operating or giving radiotherapy to most men in Australia as it stands at the moment. So it's suitable for men with low risk disease. It has excellent cancer-specific outcomes. It spares the risks of overtreatment, and it doesn't replace curative intent if you need to in the future. So for some people, it's going to be deferred treatment, but it defers it until the treatment is needed. So until that person is actually going to derive benefit from it, when their cancer actually become nasty, but spares all those other men from having unnecessary treatment. There's a great paper that's been published recently. So there's, J-Urol, which is, Journal of Urology, very big international reputable journal, looking at the long-term risks of metastasis in men on active surveillance for these early stage prostate cancers, looking at grade group 1 and grade group 2. And if you look at these patients, whether they're grade group 1 or grade group 2, their risk of metastasis following these men up for 7 years is extremely low. If these men are not getting metastases when you follow them up, then they're not dying of their prostate cancer. So it's using metastasis as a surrogate marker, basically an endpoint, which would be indicative of death from prostate cancer. So if the volume of men getting metastasis is very, very, very low, we're talking about 1 or 2%, then the number of men dying from it is going to be very low. That doesn't mean that they're not needing treatment, however. And so if you follow these men up over time, dividing them between grade group 1 and grade group 2, so the grade group 1 patients, as you follow them up to 7 years, about 75% of patients will still not have needed treatment. So the grade group 1 disease patients, about 25% roughly, if they've got low PSA density, will avoid treatment. If you've got a PSA that is high and rising, then those patients are more likely to require treatment. So this comes back to that question that we had before about PSA changes for the man on active surveillance. And I can't give you specific information without your cancer information in front of me. Your PSA velocity is important, but so is your PSA density. Your PSA density is the volume of PSA per unit tissue of the prostate. So for patients who have smaller prostates, if they've got a higher PSA, the density of that PSA is going to be greater. If people have really large prostates with relatively low PSA levels in the blood, then they've got a relatively low PSA density. The implication is if you've got these high PSA density glands, they're going to be more packed with prostate cancer cells, which are going to be active, and these patients will have more aggressive things that will progress and need to have treatment done. And so if you've got PSA densities that are relatively high in grade group 1 disease, then they're going to behave more like grade group 2, the 3 + 4 = 7. They're pretty much line ball. And so those patients are going to likely to require treatment by the time you get up 7 years. About 50% of those patients, maybe a bit more, will need treatment at 7 years. But their survival overall, so whether you have treatment now or you have treatment sometime over that 7-year journey, is excellent. So these people are all monitored as if they've not had their surveillance. They've monitored what their overall outcome is, and deferring treatment is very safe. So to go back to the chat before, if your PSA density is high, then you're still safe, but you may end up in a scenario where you end up needing to have treatment done. If your PSA density is low, that's a reassurance. You're probably likely to continue with PSA density into the future. Surgery, these pictures come from a patient education video I show to all my patients coming to me for an operation. Surgery is the mainstay for most patients who are not going down a radiotherapy pathway. And radical prostatectomy done by a keyhole robotic approach is where we're looking at the moment. So it's the treatment that we do for organ-confined prostate cancer and some select patients who have a need for a multimodal treatment. Alternatives include active surveillance for the low volume 7s. We can go down the path of external beam radiotherapy, and brachytherapy seeds were done, but less commonly done nowadays. We would generally do surgery for people who would need curative intent. We can do it with or without a nerve spear. I can do it with or without a lymph node dissection. And I can do it for people with a high-risk disease, often after I've discussed them at a multidisciplinary meeting, which I'm involved with regularly up at the SAN. And that'll be surgery potentially with androgen deprivation therapy, and maybe with some radiotherapy as a bolts and braces on the side. There'll be a few select cases where I'll do a salvage prostatectomy, which is where they've had radiotherapy which has failed. And there'll be people occasionally where we do a cytoreductive prostatectomy. These are for patients of mine who come through with PSAs, often around 100, who have local symptoms. They've got metastasis in bone or lymph nodes, but they're otherwise young and healthy outside their prostate cancer, but they've got awful local disease. I can't cure their prostate cancer, but I can get rid of these locally invasive obstructing prostate cancers, give them good local control, and then they can have their surgery followed up with radiotherapy or androgen deprivation therapy or chemotherapy or combination thereof. They do actually quite well despite their PSAs of 100. We follow them up, and for several years now, they're doing well from a quality of life. I can't cure them. I can't promise a 50-year-old man with a PSA of 100 a lifespan of another 30 years, but you should be able to give them a good life expectancy and good quality of life moving forwards. Who can't we do surgery on? It's really going to be those who have tumors involving the rectum, tumors that are involving into the bladder, going out down the urethra, truly bulky nodal disease or disease outside the pelvis. We can't do unless it's this palliative cytoreductive pathway. When I say that you can't do the T4s, it's a bit of a lie, because you can, but it's not a prostatectomy. That becomes a true exenteration where you take out the whole kit and caboodle. So you take out the bladder, you take out the prostate, you take out the rectum, you take out everything, and then people end up with permanent bags to drain the feces, so colostomy, and they've got an ileal conduit to drain the urine. It's big stuff, and unfortunately, it doesn't cure the prostate cancer, and has such major quality of life changes attached to it that it's very rarely done. Once or twice a year, and generally gets done at RPA, where they've got an exenteration institute. Normally they do it for their bowel cancers, not their prostates. There'll be people for whom we don't do prostatectomies on, and that's all radiotherapy. And that's going to be people who have a relatively poor life expectancy. So if your life expectancy is less than 10 years, then there's not a huge advantage going down the path of doing curative intent surgery, or is there a benefit to going down the path of doing curative intent radiotherapy, because it's unlikely that person will derive cancer-specific survival advantages for that. Alternatively, if they're otherwise young but they're not fit, they've got underlying lung disease, they've something else that means that they're not fit for an operation, then they're not fit for an operation. We need to look for other ways to go treating that individual. Occasionally, I've had other anatomical considerations that mean that they're not suitable, and there'll be some patients who they're just not willing to accept the risks of incontinence or erectile dysfunction, that can be attached to surgery, in which case treatment is going to be a challenge for them because those same risks are attached to radiotherapy as well. I do almost all my surgery through the Da Vinci system, which is a robotic assisted approach, which allows me to sit at a console and use some fine instruments to try and tease out the prostate from its surrounding structures. So we've got these robotic controlled arms. When I say robotic controlled, it's not really a robot, it's a drive-by-wire system. So the machine is not doing it of its own accord. I have to control the instruments. So I move these instruments, sitting at the console, and as I move my hand, it moves these arms, but it filters out any tremor, which I don't have, but not yet anyway, but it filters out the tremor if you were to have it, but it also magnifies the movements or decreases the movements depending on how you've got things set. In general, I try and have it so that as I move my hand like that, it'll only move it about a third of the way. So some very fine motor control with my fingers is even finer within the movements internally. And so it means that these, precision is going to be significantly greater than what you can do with a human hand. It also allows for extra physiological movements. So the human wrist has a natural ability for what it can twist around, whereas the Da Vinci robot allows you to keep on twisting with extra degrees of freedom above and beyond what the human can do. So it's a master-slave system. The robot's really just a branding. So I, as the master, control the slave, which is the robot, and it does what I says it or tell it to do. We do it as a keyhole approach. Like all keyhole surgery, we need to put in a little port and then a few additional ports after that, which allows us to come down to where we're doing the operation. Potentially, we can go down the path of doing nerve sparing. So nerve sparing can be done in an open approach. It can be done within a keyhole approach. Allows us to slowly tease off the erectile nerves. In general, if you go doing a nerve sparing approach, you should be able to preserve some degree of erectile performance, but the function is not going to be the same as for a person who is in their 20s or 30s and does not have prostate cancer. Unfortunately, everything in life, it really doesn't matter whether it's medicine or other facets, is about looking for the trade-offs which are the most acceptable to the person. Unfortunately, prostate treatment of some sort is associated with trade-offs. A case for me for who's an excellent functional recovery, and this is something that he's actually given the photos to me to use for talks. He's a 56-year-old farmer from West Wyalong who's come in diagnosed with multifocal Gleason 7 prostate cancer. A couple of months later, he's come up from the country to Wagga to get his to the Sand to get his robotic prostatectomy. At day 3 and day 4, he was hiking in the bush tracks around the back of the hospital. So he was keen to avoid, I was keen to avoid him getting back to the farm because I knew he'd be doing stuff like this. So instead he was hiking around the hospital's bush tracks, which you can do after a keyhole operation if you're young and fit and keen to get going. At day 5, here he is back on the tractor feeding his animals with his catheter still in place. He's had his trial of void done a week or so after that, and he's continent back at day 0. Years on, he still remains excellent with a PSA that was undetectable. I think when I made this slide, it was 2019, but here we are years on, and he's doing well. He was back as an international target shooter at 8 weeks. So the recovery post-surgery can be excellent for most individuals. Radiotherapy is a good option, not an operation, good option for a lot of individuals as well. The cancer-specific survival attached to radiotherapy is the same as for surgery, so one is not clearly better than the other. And I'd encourage a lot of my patients to get a radiotherapy opinion attached to it. Unfortunately, radiotherapy is not without potential risks of trade-off, much like surgery isn't either. The main risks from radiotherapy are going to be damage to surrounding structures, including the bladder and the rectum. When they go doing radiotherapy, they do a mock-up, so they do some planning, which is what this image is on the right-hand side. The purple is the prostate, and then the rectum and the bladder are going to be the yellow and green areas respectively. Patients move and patients breathe, and the radiotherapy has a bit of fall off as well. The radiotherapy is delivered normally over multiple weeks, and the accuracy, whilst great, is still going to be such that there'll be some fall off into surrounding structures. And as a consequence, there will be a bit of collateral damage to those abdominal organs or pelvic organs, which needs to be taken into consideration. Those effects on those surrounding organs may be both early and late. And as a consequence, radiotherapy is generally going to be better served for patients who are older, which are doing the 70, 75 plus individuals, as opposed to the younger people, because there's really no cure for radiotherapy damage to the rectum nor damage to the bladder. And if you're damaging the rectum of a 55, 56-year-old, that person from a prostate cancer perspective is going to live a long life, but they might have to live another 30 odd years with significant issues from rectal irritation or bladder irritation. It becomes very hard to go treating. Radiotherapy can be given, there's lots of different flavors, whether you do IMRT or SABR or SBRT. They're all variations of a theme. Proton therapy, which is another form of particle that you can deliver, but it's really a form of external beam radiotherapy. High dose rate brachytherapy had been given historically, but not done anymore. Low dose brachytherapy seeds has largely been replaced by radical prostatectomy with a nerve sparing approach for people who are keen to preserve sexual function, or active surveillance. So low dose seeds were good for people with low risk disease, but as we've found out, low risk disease we can safely monitor, and so in which case the role for seeds is really largely evaporated away. Focal therapy, something that you may have heard a little bit about. We're still at the place where we don't yet have enough evidence behind it. We're going to get there soon, I suspect, but the real hard thing is trying to find the patients to target, like who are going to be the appropriate patients, and patient selection, because the imaging, whilst good, is not perfect. This is a paper from Nathan Larenchuk, who's a Melbourne-based urologist, and a couple of other individuals from overseas, looking at the role of focal therapy for localized prostate cancer. Interesting, the paper's from 2013, and the situation has not changed much since then. Essentially what they're saying is that focal therapy as a focal treatment for prostate cancer looks good. You get good perioperative and functional outcomes with encouraging short and medium-term follow-up. I said before about the people who write letters back saying PSAs look great at 3 months. They will do. What we need to have still is long-term follow-up, and focal therapy doesn't have that. So it's coming, but we're not there yet. So we don't yet know that it is not inferior to the traditional radical treatments. I think there's going to be a middle role where focal therapy will come into play for people who need that step between active surveillance and radical treatment. But we're just not quite there where that middle ground is going to be appropriate for everybody. There's a lot of different treatments that have been offered for focal therapy, be it cryoablation, water vapor therapy, HIFO, nanoknife oil with the branding for electroporation, laser therapy, photodynamic therapy using porphyrins. In general, if you need to try multiple different treatments to try and tackle something, it's because you're looking for a better mousetrap. If any one particular treatment that branded itself as focal therapy was robust, then you wouldn't need to have 7 or 8 different competing treatment options available. That's my take on it. Is there going to be something that comes to the fore in the future, or maybe we've got it here now? Maybe we're just not quite there yet. The concept of focal therapy is that you have your tumor, your dominant tumor, and you can hemiablate it by targeting just it. You can take out a quadrant, or you can take out half, 3/4. You try and update, so try and tackle your tumors where possible. The problem is that prostate cancer rarely is going to be so neat. A lot of tumors are going to be multifocal. So when I go tackling prostate cancer, yes, I've showed you some MRIs before with the dominant tumor. Once I go doing an operation on patients, what we generally go seeing is that when things get sectioned up under a microscope, the tumors are multifocal. So it's like an orange or a bit of fruit that's starting to go bad. You've got your clearly rotten bit, but the rest of it's starting to go a bit rotten as well. And focal therapy is not able to really account for those. It's really much dependent upon imaging, and imaging, whilst good, is not perfect. And we don't really know how to follow them up long term. We don't know how to go down the path of retreating them if there's failure. So this is a patient of mine from previously who's had potential focal therapy candidate because he had grade group 2 disease on biopsy. However, his biopsies have shown actually he doesn't have grade group 2 disease. He has grade group 3 disease. So he's gone from a 3+4 to a 4+3. He's got multifocal prostate cancer involving all quadrants of the prostate. And actually the big tumor that he's got at the top of the prostate is actually starting to extend beyond and into some of the fat structure at the top. So he's got extracapsular extension. He's got T3 disease. My surgical margins are clear. Had you done focal therapy for him, he would have been undertreated. These are young individuals, and we're dealing with cancer, which can cause significant harm to patients left undertreated. The science just isn't there yet. This is another patient who again has had nominally relatively low risk grade group 3 disease, nominally relatively low risk, it's intermediate, so to speak. But they've got prostate cancer extending into the periprostatic space. They've got extracapsular extension, and they've got seminal vesicle involvement. And that's what my prostate cancer patients look like. So this is what tumors look like. They don't look like this nice model that we had before with a single prostate cancer just waiting there for you to actually go targeting it. Life is not so neat, unfortunately. So focal therapy as an option may be there for a select group of patients, but I don't know if it's going to be there for everybody. This is another patient. This is what their pathology reports come back as. So they're at 3+4. There might be a good focal therapy patient nominally, but again, they're not unifocal. They're multifocal. Lots of different sites of tumor popping up. There's no really left or right zone of the prostate that you can target without getting the whole prostate. The whole prostate for that person is starting to go rotten. They really need to have disease treatment. This is a slide that I saw at a conference previously, which is who do you think really has organ confined versus non-organ confined disease? When you actually go through and do audits of all these data, Gleason 6 disease is almost invariably going to be organ confined and not spread elsewhere. 3+4, 10% of these patients will have disease spread beyond the prostate. 4+3, 40% of them are going to have disease spread beyond the prostate. So focal therapy is trying to sell itself at the moment as something that we can go doing for people with low volume 3+4 or 4+3, the Gleason 7s. Unfortunately, 40% of those patients, if they're grade group 3s, or a disease that's pushing out into the areas beyond the prostate, that periprostatic space, in which case, the focal therapy is not really going to deal with that area. That's the area where the nerve tissue are, which is what prostate cancer focal therapy is trying to spare. Unfortunately, we just don't have the 10-year data on these people to see where the failures are happening and what their long-term harm is going to be. So we need more robust studies. We're just not there yet. Is there a desire to find an ideal patient and treatment combination? Absolutely. Do I think there's a role for it? Yes. Are we there yet? No. So 2022 focal therapy is not yet ready for mainstream. Androgen deprivation therapy, which a lot of you will be aware of or potentially on. There's some quality of life impacts attached to it with bone health, metabolic changes, libido can change, and significantly increased risk of cardiovascular disease. And this is the important take home, is that men with prostate cancer die of prostate cancer, but they also die from heart disease. And more men with prostate cancer will die of heart disease than their prostate cancer. So we need to look for judicious use of androgen deprivation therapy, which accelerates heart disease risks. Ideally, we use intermittent androgen deprivation therapy, or altogether go back to a timely diagnosis. So we can get a timely diagnosis and early treatment, but hopefully is that we can avoid or postpone the androgen deprivation therapy and the late life effects from it. I touched on obesity and malignancy before. It's worth mentioning again. Regular exercise and weight loss should be considered routine care for patients with prostate cancer. Proactive referral, I try and encourage my patients, particularly those who are clearly overweight, that they need to lose weight. There's a MAN plan program which the Lucran manufacturers support. There's other companies which will have its exercise physiologists attached to it because they recognize the utility of getting people doing weight loss, particularly if they're on androgen deprivation therapy. But people who are young, newly diagnosed, there's going to be significant improvements in their outcome if they lose weight. People listening, if you're not exercising, you should be. If you're carrying too much weight around the middle, it's helpful to try and lose that. Excess alcohol, excess sweets, excess sugars. Try and bring them all down. Medical oncology, I interface with medical oncologists, but I'm very much not a medical oncologist. We no longer view them as late stage doctors. We're generally trying to blend them into the clinician sequence. And there's a role for getting people into chemotherapy options early on in the piece, sometimes even pre-surgery. 10 years ago, the surgical space, the oncology space looked sort of like this, where you had limited options. And now here we are, and we move forward to 2019, 2020, and the space has changed significantly. There's lots of options. There's lots of clinical trials that are starting to come through, and where you're putting these patients in any one particular time frame changes based upon the trial data at that particular point in time. It's too much for me to keep up with. I interface very much with the medical oncologists because that's what they do, and they do it very well. Gavin Marks at the SAN offers an excellent program, and as does his team through the centre there. So in conclusion, so there's been a lot of talking, there's mounting evidence to offer PSA screening. US PSTF just updated its guidelines again to recommend it. So they've essentially got a Mark II statement, and denying men a timely cancer diagnosis helps nobody. So head in the sand approach, I can't see benefit for. Transperineal biopsies are safer and replace the transrectal. And thanks to us in Australia, it's rapidly becoming the standard of care internationally. Active surveillance, important take home that it's going to be the mainstay treatment for a lot of individuals, and really helps to confer excellent disease specific and personal risks minimization for patients moving forwards. Radiotherapy, I'm a surgeon, I work very closely with my radiotherapy colleagues. I try and encourage all patients to get a radiotherapy opinion particularly if they want one, but even if they don't, they should have one. Not everyone wants it, but it's a utility for a lot of individuals, particularly the older men. For the 50-year-old, it's a pretty clear-cut case. The radiation oncologist is not going to suggest that person has radiotherapy. That's not going to be their best interests. But radiotherapy is an excellent option for a lot of individuals. My personal thought is it's important to have a urologist who's linked into the trials and MDTs, which is what we do at the SAN and do it very well. Any questions?
Yes. Can I ask a question, please?
Certainly.
When a man has had a prostatectomy with a curative approach for a Gleason 4+3,
yes,
they monitor the PSA afterwards and expect it to come down to undetectable. What happens if it doesn't? And does this happen is it very often you find that it doesn't go down, and is there something causing it?
It happens. It happens occasionally. And always becomes a bit of a question as to how it is that we should go managing it. The reason why the PSA might not come down is either because there's going to be residual disease or because there's residual prostate. So depends upon what the margins say. So when I do a prostatectomy, I give all my patients their copy of their reports, and so you'd want to have a look at the report, the histology report. So your patient, your body, you should have the results on hand of that. So you want to have a look at what your pathology report says. If it says that there's a positive surgical margin, then the positive surgical margin, the implication is that there was tumor where the prostate was removed, and at least going up to that. And so that gives the suggestion there may be a little bit of additional cancer cells on the other side of that margin. If the margin was clear, then that's where we're really wondering about the potential for some benign prostate cells, because you have a little tiny sliver, particularly at the apex, the downstream part of the prostate, where there is no great capsule. You can leave a little bit of benign prostate cancer tissue, which can just slowly increase in time over decades. You'll see the PSA go from 0.001 to 0.009. And the slow background PSA growth over 10 years. That means nothing. It's truly inconsequential. Alternatively, and more commonly, however, what you'll have is some micrometastatic disease. So as I said, showed you the figures before with 40% of patients or more having disease spread beyond the prostate with 4+3s. Then if you're in that category, then you have a reasonable probability of having disease spread into the periprostatic space. And then if it's into that periprostatic space, it's a T3 patient, they have a reasonable probability of micrometastatic disease. That means even if the lymph nodes are not positive for tumor, they can very well have microscopic foci of disease within the lymph nodes that you cannot detect with any imaging as it currently stands in 2022. But you can see it on the PSA. Now, that doesn't mean that man is dying from prostate cancer, but it means that they're not in remission. it means that somewhere within their body, there will be some cancer cells, and you need to monitor their PSA into the future. And if the PSA starts to come up significantly, it crosses the threshold of 0.2, we define that as biochemical recurrence, and there's going to be a role there for giving them additional treatment. That's going to be where androgen deprivation therapy or medical oncology colleagues come into play. It can be where we go down the path of doing the PSMA PET scan, looking to see if there's hot spots that we're going to radiate. They might just have one lymph node lining up, things along that sort of scenario.
So there's quite a few options depending on what you find. In other words,
No person is the same. There's a lot of options.
a lot of options is the main thing.
Yes.
Yeah. Thank you.
Unfortunately, you can't. It's not just a one-size-fits-all approach.
No, but there's quite a few possibilities to do something.
Oh yes, absolutely. And there's a lot of possible causes for why the PSA can be up. In general, the suspicion has to be that there's going to be a little bit of prostate cancer somewhere. But if it is somewhere, then there's things that we can go doing for it.
Oh, good. Thank you.
Pleasure.
Could I ask a question too?
Certainly.
Yes, I was just, you mentioned the importance of PSA density as compared to just PSA, which I can readily understand. But when we have our PSA test, we are normally told the PSA level. Am I right in thinking that we would have to have at the same time an MRI or some method of measuring the volume of the prostate?
You'd need to have a MRI or an ultrasound to get an estimate of what the PSA density is.
So how often would it be sensible to do that if you're just essentially just monitoring your PSA?
It's not required. So the PSA density is more of a statistical tool that we can use in the research space for patients who have prostate cancer, and we're trying to track metrics. For people who are on an active surveillance pathway, it's not going to change the commencement of active surveillance for that patient. So for people who have doesn't really their PSA density doesn't come into play. If I have a person who I think is suitable for active surveillance, then active surveillance is the appropriate option for them. Obviously, I do that with discussion with the individual. But if they're an AS patient, then their PSA density doesn't come into play. I'm going to always give them the benefit of the doubt.
I see.
So you'll go in and you'll go into surveillance and you'll monitor them. And you can come after the fact and say, look, your prostate was small, your density is high. In and of myself, I know when I see people in the office that their prostate is small, and I will tell people, in front of me, often they come in from their GP with a PSA of 5, and I examine them, and their prostate is very small. The MRI is showing a prostate volume of 30 cc's. It's a normal size. So I know in my heart of hearts that there's something going on, and I tell them it's small and suspicious. The patients don't quite understand that small is not protective. They think small is good when it's not.
Thank you.
May I ask a question?
Yes, certainly.
A number of guys that I talk to appear to be having the same problem as me with incontinence after surgery. I just wonder what your thoughts are about having a sling fitted, the pros and cons of that.
That really depends upon what treatment you've had so far going through, but as a general rule, this is where I sort of would suggest that getting that BPH stuff sorted as an earlier man is going to be of utility to try and tackle the overactive bladder. There's a role for surgical intervention, but you need to make sure that people have gone through the medical management pathways first, because for a lot of people, it's going to be that they've got an overactive bladder. They've got something that we can control with medication like Betmeger or Mirabegron, or solifenacin. There's Ditropan that you can go give them to patients to control their bladder urgency. If medications have not worked, if weight loss has not worked, so some people are just be morbidly obese or obese, and their pelvic floor strength is okay, but they're just not okay with the patient's weight. The patient's weights come down to a normal size and they're still leaking, then definitely slings or sphincters are a great option. The slings have less trade-off attached to them than the sphincter. I've trained in putting both in. I don't do them anymore because I don't have enough need for it. So I have a couple of colleagues who I'd refer to on the rare occasion that it's required. But it's only a handful of patients a year that from my experience will need it. But certainly if they need it, I'd encourage them to get onto it early in the piece. Like I can't see, if you're 2 years out from surgery and people are leaking, there's, and you've already gone down the path of maximizing the optimizations that you can do, then they're probably not going to become dry, in which case the person's quality of life is suffering. They're better off to have a sling or a sphincter put in.
Okay, thank you.
Do we have any other questions?
Well, I could ask one other if you don't mind, and that is, I'm curious about the role of genomic testing as an alternative approach, which you didn't mention there. I'm not saying you should have, but I'm just, I've had it myself. I'm just wondering whether it's becoming pretty widespread in Australia, or what your opinion about it is.
Genomic testing has little role, actually. So how was your genomic testing done? Was that prior to treatment, or was that?
Yeah, it was. I have not had treatment, but I had the biopsy, and the biopsy was refrigerated, and then it was sent to America, which was the only way to do it at that time. And then I got a reading from that, which was that I had 7.6% chance of dying from prostate cancer in the next 10 years. And so I accepted that. That seemed to me a reasonable risk. Anyway, I was just curious. I think it's becoming a bit more readily available in Australia now.
Potentially, the genomic testing has never been validated in any significant fashion. It's been around for the best part of 10 to 15 years and has never caught on because it's never been very good. And I don't want to invalidate your experience.
Can I ask what you mean by it's not very good?
It doesn't change patient management at a significant level. So the genomic testing was a way of trying to get improvements in detection of patients who had transrectal prostate biopsies in the pre-MRI era before PSMA PET scans came about. So it was looking to, in your scenario, looking to assess for some of these SNPs, the single nucleotide polymorphisms that would be associated with DNA variation that might predispose patients to more aggressive prostate cancer. These are from tests with abnormalities that were known about historically, not ones that are necessarily known about now. So they're not quite as accurate as whether the current DNA testing will be. And we're looking at tests like the Oncotype DX and some of those ones. The testing, unfortunately, can be done better. And so, if you're wanting to send, the reason why you'd be having it is because you had your biopsy done, which would have found cells X, Y, or Z. But it's a bit of a scattergun approach where you go putting in your needles historically, and because you didn't have an MRI to target it, and so you didn't know that you're hitting tumor here and not tumor there, or your needle was there and it wasn't here. The concern was, like I showed you with a map of the multifocal prostate cancers, is that you're hitting one group of cells and you're hoping that there's not a larger group of cells in the field immediately around it. And so the thought was, in the area around where these tumors are, they will, within the intercellular milieu, have this spread of stuff that will change the DNA around the immediate prostate cancer, the higher grade disease. But that's true maybe for tumor here, doesn't have anything to do with tumor there, and how things will evolve over time. And it's not been shown at a large population level to impact upon patients' survival curves or survival outcomes. And so we've got better tools now. We have PSMA PET scans and the MRI scan, so you can go and do a more accurate biopsy. You can do the MRI targeted biopsy, and you put patients onto a surveillance protocol. And then you do MRIs to surveil those patients. You actually look to see on the prostate where are things changing in semi-real time. Do a PET scan looking to see where are things PSMA avid. It gives you a more accurate area of showing where the high-grade cancers are. You can target those things with some biopsies as well. Transperineal biopsies are as safe as can be. It's a procedure, but it's very safe. It can be done under local anaesthetic in select patients. So it's a safe ambulatory day surgery type procedure. Whereas using a static snapshot of time from a DNA test done historically, doesn't bode well for the future, and it's not been taken into any sort of cancer metric, any guideline around the place. So there's no role for it. Doesn't mean that companies won't make money out of it. Doesn't mean that people won't sell it. But just because it's commercially available doesn't mean that it's going to fit into any guidelines, because there's no role for it that I can see. Now that's different to genetic testing for patients who will be having some of the chemotherapy or PARP inhibitors. So I didn't really touch on PARP inhibitors, which are another type of cancer-related treatment, which are given by the medical oncologists. Different types of cancers will have different genetic abnormalities attached to it, which will alter how they will respond to different types of chemotherapies or drug therapies. And so at a cellular level, at a genetic level, I should say, you can select which patient should get treatment X or Y, because you know that they're more likely to respond or fail. And there's no point, hitting your head against a wall, hoping that's going to work if it's still going to be a wall, it's still going to hurt. At the end of the day, if your genetic test says this person's not going to respond to treatment Y, there's no point giving them 6 months of treatment Y and wondering why the PSA keeps on going up. So there is a role for genetic testing in prostate cancer, but it's really in the late stages, and it's done by the medical oncologist, not by myself. There's a role for genetic testing for patients who have concerns about familial prostate cancer. So if I have a man in their 40s who has prostate cancer, then unfortunately it's a bit late for him to have his genetic testing done, but there's going to be a role for him to have genetic testing to see if he's a BRCA carrier, because if he is a BRCA carrier, that has impacts upon not necessarily himself, but will have impacts upon his offspring and also upon his siblings, because they will also be at risk of having early and aggressive breast and ovarian cancer.
Brilliant. Dr. Symons, any more questions, anyone? All right then, so I'd like to thank you, Dr. Symons, for your excellent and informative presentation tonight. Look, we really greatly appreciate the time that you've spent with us here tonight. You've gone well over the allocated time, but it was so informative, and there's so much material in there. I felt it was just worthwhile we kept going. So I really appreciate you putting in that extra time for the presentation. It was very valuable.
Not a problem.
And so again, just thanks on behalf of the support group here at the stand, and really appreciate your time.
Pleasure. Have a good night.
Thank you very much.
Thank you.
Thank you.
Take care, everyone.
Bye-bye.
Thank you. Yep.
Thank you.